Hello, welcome to the joint HOSC. I am obliged to inform you that this meeting is being live streamed and recorded. Okay, so if we go on to apologies, I've got here Steve Charmley, Heather Kidd and David Sambach. Have any other apologies been received?
No.
No? Okay, that's great. Item number 2, declarations of interest. Does any member wish to make a declaration of interest into any on any of the agenda items?
I suppose I better from this farmers list.
Oh, sorry, could I just ask you to turn your microphones on, otherwise your voice won't be picked up on broadcast. So it's the right hand button for anyone that's not familiar. Thank you.
Okay, so I'm Councillor Nigel Dunmore. I also operate a community pharmacy in Darlington, Telford.
Okay, thank you. Are there any other declarations of interest? No? Okay. Minutes of the previous meeting, which was held on the 23rd of January 2023. Could I have a proposer for those previous minutes? Thank you, Derek. And a seconder? Thank you. Could the people who were in attendance at the last meeting vote on those minutes? Is that okay? That's carried. Just matters arising from the previous minutes. The officers are following up on the point in the previous minutes where members requested further examination of funding in maternity services at SAP and requested that this be provided at a later date. That is being followed up. Okay, let's move to item 4. And Claire Parker from Shropshire, Telford Wrekin NHS is to present her item.
Thank you very much. Hopefully you've all received a copy of version 9 of the joint forward plan, which is still in draft, with due to publish on or after the 30th of June. So it's quite a different version from the draft that is published on the website at the moment, which is really an amalgamation of lots of information from partners around the sort of things that we wanted to put into the joint forward plan and describe to the public, our partners and stakeholders, what our plans and ambitions would be for the next 5 years. The plan is to deliver the health and wellbeing strategies from both of the local authority health and wellbeing boards. And actually what we've tried to do is get this new version to align to that strategy so that we're demonstrating how we start and deliver that plan. It's a collaborative plan, so it isn't just an NHS plan, although we do have to get assurance from NHS England and recommendations, which we have done, and we got the last lot of feedback yesterday actually, and there are still some bits that we need to do some further work on. So, for example, the quality section is still quite short, so we want to put more in about quality, linking how we use data, particularly around some of the inequalities, the health inequalities, and how that maps to some of the person-centred care and the strategy, the health from the health and wellbeing strategies. So that needs tightening up a little bit. We've had some really good engagement through the community voluntary sector. From carers. We're strengthening some of the maternity voices within the plan going forward. And then there's one or two other little bits around some of the finance, how we get out of our national oversight framework, level 4, and we've also been pulling through some, not all yet, of the engagement that we've been doing through the big conversation. I know there have been some questions that have been raised in relation to the engagement and the numbers. I don't have them. That's the director of comms, and I've let Sophie know. We have got it. We just need to make sure that we circulate that after the event. Before the publication of the draft, we did a number of engagement events where we invited members of the public to attend big conversation presentations. But since the end of March, we've been going out to those seldom heard communities and engaging with, as I say, community voluntary sector, parent and carers, and our comms team, and some other community voluntary sector volunteers have been going out to some different groups around learning disabilities, mental health, children and young people, and so on. So we'll make sure that we get all that data so that you can see that. What we're now trying to do is make sure that's reflected in the plan. So throughout all of the sections, how are we delivering the you said, we did, or we're thinking about, or we're going to add that into our ambition so that it's clearly reflected within the plan. We need to reflect the challenges obviously around finances and workforce, and then some of the management resource that that will be reduced over the coming 24 months. So those are the elements that we've been looking at, but I'm really happy to take any questions or feedback on the plan, because we've still got a couple of weeks to get it to the ICB ready for sign off. And Rachel's just walked in at the right time because she's been supporting, as has Liz Noakes, for Telford and Wrekin. So I'll stop there and just take questions. I'd rather do the discussion than me talk.
Okay, thanks very much for that, Claire. Would any members like to put any questions? Yeah, Louise.
Hi there. I've just got a few questions. You've mentioned in the report that you're wanting to mitigate digital exclusion to reduce health inequalities. What are you proposing to do to address this, bearing in mind Shropshire is predominantly very rural and there's areas of very poor internet and mobile phone coverage?
Yes, we had a discussion about that yesterday. We have a digital strategy, and that the joint forward plan will link to the digital strategy, and there is more detail about how we're going to work through the digital exclusion. What through our executive meeting we agreed was that actually digital exclusion isn't clear as a priority, so we're going to make sure that's clear as a priority in the digital strategy, and then work through co-production and engagement about how we address some of those issues to promote that. We've had through the engagement events some ideas from those areas where broadband access, email, mobile phone signal is a challenge, and what we could potentially do to address that. So we are going to feed that through into the plan. If there's any more that anybody else can think of to help support that, be great to hear from you about it. And the digital strategy is going to be circulated for engagement and comment, so it'd be a good opportunity to discuss more of the how through that.
Thank you. Would you like to put? Yeah.
Yeah, I'd just like to come in on that. I've heard that there is a social task force looking at digital exclusion that I've been invited to go along to, and I just wonder if it wouldn't be helpful for that task force to invite Claire or someone involved in the forward plan so they hear what that conversation is happening, because it's very live at the moment.
Thank you, Councillor Kate Halliday.
Thank you. Yeah, I had a question about community pharmacy, although I didn't realise I had a pharmacist here who'll probably be able to help. Right, okay. You mentioned the recovering access to primary care and you know, it's nice to see discussion about expansion of community pharmacy, but I'm also aware that there are kind of significant issues with community pharmacy as well, and community pharmacies are closing across the country, and I know that a lot of the new plans focus on perhaps freeing up capacity in GP surgeries and directing things towards community pharmacy. I think I'm very capable of doing a lot of what's suggested in the plan. But I can see there's a bit of a plan here, but I guess my question is, do we feel that community pharmacy is going to be able to cope with an expansion?
I should probably declare I used to be a community pharmacist as well, so this is an area of real interest. We are going to develop the community pharmacy in the dental sections a little bit more, certainly off the back of a discussion through Telford and Wrekin Health and Wellbeing Board about non-medical prescribers, so pharmacists that can prescribe, and certainly within the primary care access report using community pharmacy to prescribe more, and as you suggest, take some of the strain off GP practice, but the workforce issues in community pharmacy and the financial issues around the pharmacy contract are still of a concern. So we do need to make sure that the community pharmacy issues are mapped through our workforce planning and our people plan. We have got at the moment a member of staff who's a community pharmacy liaison for the ICB, who's working with the local pharmaceutical committee and community pharmacies to develop what the plan looks like and how to work through the recovery access plan. And I think this joint forward plan isn't going to stop as a document on the 30th of June. We need to keep developing it and moving our ambition forward and refreshing it on an annual basis. So believe me, I'll be taking a personal interest in the community pharmacy section because I'm also a non-medical prescriber. So
could I just ask a quick follow-on question from that? I mean, just because I've mentioned the primary care recovery plan, it's just a follow-on from the excellent point that was made earlier about, I know that a lot of it is focusing on improving a kind of digital system within GP practices, and I was reading that something like 50% of primary care still has an old analog, phone system, not a digital one. So I'm not sure if I'm asking a question exactly, but I guess it's a comment about we're going to be really inhibited. Well, do we know how many analog versus digital systems we have already? And it could potentially inhibit the plans to improve access to primary care if we are struggling in that area.
I don't know exactly how many analog systems we've got, but I know the primary care team, as soon as we've been doing a lot of work around telephony access, and since the recovery plan has come out, they're working through what the implications of the plan are on those phone systems, and the investment that will be needed across Shropshire, Telford and Wrekin to upgrade those. I would make a recommendation, not necessarily linked to the joint forward plan, but that perhaps primary care come to a future joint HOSC to talk about the recovery plan and what some of the actions are, and invite some of the GP members or PCN members, clinical directors, to just come and talk about the recovery plan and the impacts that it's going to have on primary care across our system.
Thank you. Please could I bring Rachel in?
Sorry, thank you. I'm Rachel Robinson, Executive Director for Health, Wellbeing and Prevention at Shropshire. It was just to answer the question that Louise raised and then responded to around the social task force. So yes, we have a social task force that's been picking up the work around the cost of living within Shropshire. It's a partnership, and one of the issues that has been flagged rightly is digital exclusion. So we've got a focused meeting actually tomorrow, where we'll be looking at some recommendations around establishing a digital exclusion network, with the idea being that one of those that policies and programmes can be brought through that forum made up of interested partners, counsellors, voluntary sector, etc., to make sure who've got a good understanding of this, that we can run back past policies, programmes, issues through that group as one of the things that they'll be involved in to mitigate any issues around digital exclusion. So I think that's an excellent suggestion that Lynn's made, that we could utilise that forum if it's approved tomorrow at the task force. Thank you.
Could I go to Dag and not come to you next?
Blimey, yeah. So apologies, I've got a very significant number of issues. I only got about page 70. So you'll stop me when you get fed up. I've tried to approach this with a scrutiny line, because scrutiny, we're not here to scrutinise individual clinical issues. We're here to look at the broad picture. Although the amount of information in the document we have is very interesting, enormous amount of information, a lot of it really very interesting, which I obviously like to ask lots of detailed questions about that. But trying to cling to the fact that that's not entirely what our role is. I have to say, first of all, that I think the ICS did a good job in their big conversation. Got around to lots of people and worked really hard. Not always the best way of getting views. Public meetings, they often get taken over with single issues. I mean, I suspect the Shrewsbury one had a particular focus on the hub, I suspect, and Bishop's Castle might have been interesting as well, although our Bishop's Castle councillor isn't here today. The big picture is that we have an acute hospital system that's in special measures and has been in special measures for a long time. We have an ICS that's under the STP, yes? Not the STP, the recovery plan. Sorry, the recovery plan. I sink into initials, and I'm afraid that the whole thing has got a lot of initials. We've got big issues on staffing, obviously finance, and a lot of the elements in the plan. I mean, you can hardly argue with any of them. But the real issue is, how on earth are we going to possibly sustain development with a growing population, with more older people, with problems staff? So a few specific questions. How many hospital doctors are we currently short of, and how are we going to replace those over the next 5 years? Same for nurses, hospital nurses and primary care nurses, most important. And the community trust appears to be struggling in terms of staffing. And yet we've got issues like virtual wards, keeping more people out of hospital. How are we going to address the national staffing problems when, given the background of we're in special measures, recovery plan, so it may be Shropshire, Telford and Wrekin is not the most attractive place for professionals to come to in their career. How are we going to get over those big issues? We've got some, obviously, finance issues. What's the current backlog in terms of clinical equipment? Because that was pretty significant 2 or 3 years ago. Where are we standing now in terms of maintaining our clinical equipment in the hospital, particularly and also in primary care? The big issues locally are people not being able to get through to their GP. We've got a lot of doctors' practices, GP practices, that are working on outdated telephone systems. That doesn't help. We've got hospital waiting lists. What's been the impact of the industrial action that hasn't finished yet on waiting lists? So how are we dealing with waiting times, particularly outpatient waiting times? Those are the issues that the public have major concerns over. Shall I move on? I haven't started yet, really. The challenges on page 16, which you pick out. Sorry, so we have to whip through this. The challenges that quality, service recovery, workforce sustainability. So I've tried to include those, but how do we deal with those challenges? I mean, they're significant things. And I see a lot of good intentions, but I'm not sure I see the detailed actions that are going to deal with all of those. Amongst the challenges, we've got the ageing population I mentioned already, and growing population and ageing population. So in many cases, particularly in the acute services, we're talking about reducing demand, but we've got a growing population. So, if we maintain the level of demand with a growing population, we'll still be going backwards. Can I ask, I'll flit around and try and pick up some of the big things here, but there's many, many things I've written down. On primary care, we have raised the Taunton Vale model of primary care, of GP practice. I mentioned this to the ICS about 4 months ago. How far have we got in terms of analysing that as a possibility for rolling out to local practices? Is the Taunton Vale system, does it work? Have you analysed it? It seems, on the surface, it seems to be dealing with a lot of the issues in the GP services at the moment. So surely, if it's working, we should bite their hand off to try and do it here. Or is there a reason why in Shropshire, Telford and Wrekin it wouldn't be relevant? If someone's found an answer, and the NHS is not brilliant at learning from other areas, we know that. Is that something that has that been looked at? I hope it's been looked at, because I raised it about 4 months ago. And I hope there's been I hope you visited Taunton, looked at it, discussed it with the practice there, and decided whether it's something we could use here. There's a number of examples scattered around. I'm flying around this whole thing, I know. A number of examples. One of them, I think, is Rockadine Wood School. Another is there's some examples in the document of what appears to be good practice. How are we rolling those when something works, like the Rockadine Wood School, or what was the other one that was specified? Someone help me without looking through all of these. No one's helping.
Oxford Street?
Sorry?
Was it the Oxford Street? Oxford Street is highly.
Yeah. So how do we, if it's doing good things and improving things, how do we roll those out rapidly to other parts? On the pharmacies thing, we've got national indications of closing pharmacies. The pharmaceutical services are now come within the ICS, but opening and closing, maintaining pharmacies is a commercial decision taken by commercial. So how can the ICS support pharmacies that might be failing, or where we're needed because the population is growing again? And there's chunks of, certainly chunks of Telford where you've got new populations growing up, chunks of Shropshire, Shirehall, etc. How are we responding to the need for pharmacies in those areas? You haven't shut me up yet, Chair.
Doug, could I just ask that we take a small break, let Claire answer some of those questions?
Okay, yeah.
Quite a lot of ground covered, and then we can.
In your hands, yeah.
Okay, thank you.
Okay.
Claire.
I've got more.
The first thing to say is I'm not going to be able to answer all the detail of all of those questions. I mean, I'm a generalist in some areas and an expert in others. The joint forward plan is an overarching plan. So the areas that you raised that we absolutely have to demonstrate how we're delivering the workforce, the retention, the digital exclusion, the clinical priorities, the issues around quality and safety at SAF and maintaining that sustainability and primary care, which I was doing 6 months ago, so I've got a little more knowledge around that. There are detailed plans that sit underneath this. So this is the overarching plan.
The detailed funding plan, are they funded?
Yes, they have to have the funding structure underneath it. We have to recognise the restrictions that we've got around the finances and what we can do. However, the reason that we've used this plan is to look at our population health in the broadest sense. So we need to be smarter with where we're putting the money. And we've got some, as you rightly point out, some of the case studies within the plan where we're demonstrating delivery through some of the place-based work that we've done in both Shropshire, through the Falls service, which we identified as a quality issue, for example, the work that's going on in Oswestry, and then in Telford and Wrekin, some of the work that's happening around Better Start in Life and the Ageing Well work. So all of those things sit underneath this. It would be a document of hundreds of pages if we literally put all of that in. So what we wanted it to do is demonstrate the how we're going to deliver the integrated care strategy, and then for each of those issues that you raise, how do we get underneath them? I totally agree with you about the issues that the public are raising around access, safety, long waiting lists. And again, there are plans around those. I can't give you the numbers because other people deal with the detail of those. And I suggest from a scrutiny perspective that if you want the detail, that actually you think about bringing those in so you can have a look at that in much more detail. The idea of this plan is to make sure that we've got the right things with the right priorities aligned, because we can't do everything. We need to make sure that we're using the money that we have got in the right places to maximise the right things for people. And then I think the last thing that you said around the pharmacy issue, yes, it's a commercial decision. We only hold the contracts. And actually, until the pharmacy contract is looked at, and is looked at as an outcomes-based contract and not a volume-based contract, it's going to be very, very challenging to support that. And there are also a number of issues that you raise, particularly that are definitely above my pay grade because they're related to national issues that we would definitely need support from NHS England and wider government on.
Can I just say, on page 33, you've got the Ageing World Partnership Board in Telford and Wrekin. I chair that, and you can give a tick that because we have actually finished that. Although the mental element of it is still to be worked on. So we can have a tick. I've got lots more when you want me to.
Is it okay if we go to other members to ask their questions and then come back? Okay, that's great. Louise.
Sorry to go back to the community pharmacy area again, but I was a little bit concerned about one article you've got in the report, which you state many rural communities do not have access to pharmacy, and therefore some of the options to access proposed services will be a challenge. And there's nothing in the report to say how you are trying to deal with those challenges, or, you know, are you just going to ignore the rural community, or?
No. It's really difficult because obviously when you've got some of our rural practices bordering Wales that are dispensing practices, lots of our patients, public service users live a considerable drive away from a community pharmacy, and there is quite a push in the recovery document to move work to community pharmacy. Nigel will know this, particularly around additional prescribing for not so minor ailments, but things like urinary tract infections and dermatology, and some of the things that I've probably lost, the sort of things that community pharmacy can do. So we do need to look at how we can develop that. I think what we've been doing is talking to our rural practices about where some of those expansion of services are going. What we need to do is innovate and think about different ways of doing that. Now, that's very difficult to do when we're restricted financially, but that doesn't mean we stop talking. It's not making the situation any worse than it is at the moment. It's about how do we improve that access going forward. So I don't have a specific answer, but no, we're not sort of, you know, brushing it under the carpet. We're definitely sort of trying to take it head on.
Thank you. Nigel.
Yeah, thanks. Well, I didn't realise it was all going to be about community pharmacy, but anyway, great. I mean, the challenge and the reason why community pharmacies are closing is because some of them are not commercially viable. It's as simple as that. Because it's quite common for the NHS agreed price of drugs to be less than it costs for us to buy in the drugs. And how many businesses can afford to let £30–40 walk out the door with each person? And that is also contributing to the fact that sometimes you're getting shortages of drugs because community pharmacists say, well, I'm sorry, we can't get it in because they can't afford to lose the money. So therefore, there's then a hunt goes round trying to find out where it can be got from. So there are examples whereby, you know, sort of, as I say, it's been nationally in the press that there's been community pharmacists, people are finding that the drugs are unavailable, and national government are saying, or the wholesalers are saying, but it is available. And it's as simple as that. And there is a problem with the community pharmacy contract, but it's a 5-year contract. Can't remember how many years we're into it, but there's still I think there's still at least 2 years, if not, is it 2 years?
It's nearly 3 actually.
Yeah, so we're only halfway through. So that's the crux of the matter, the financial matter. Now, being a bit more positive, yeah, we can do a lot more and we can really help, but we have to have the tools to do it. I'll give you an example, if I can. Pre-pandemic, I could, if somebody came in with an ear infection, I could examine them, and if they needed antibiotics, I could dispense antibiotics. That was stopped during the pandemic for obvious reasons, and I argued to get it restarted. Now then, a service has been restarted. However, the items that we can prescribe are not antibiotics, and it's restricted to children under the age of 16, as opposed to anybody. So therefore, all of a sudden, yes, we've got a service, but it's not actually going to do what it's geared to do. So an adult comes in, if they've got an ear infection, I have to turn them away because I can't treat them, even though I could examine them and probably tell them what they needed, but I cannot treat them. So we've got to have whatever comes through with the extended services, you've got to be able to prescribe the things that are actually going to stop people going to the GPs or going to A&E. It's as simple as that. And the one thing that could be done quite relatively cheaply and would help to actually deliver these services is the fact of independent prescribers, community pharmacy prescribers, because, as you can tell, I'm quite old now. So if I've got 30 odd years experience, I know what a red flag symptom looks like. I can virtually tell people what the doctor's going to prescribe to them for minor things, and you'll know that as well. And the thing is that, however, I've been trying to get on a course to be an independent prescriber for 4-5 years. Biggest problem is not getting on the course, it's getting a GP or a prescriber to act as your mentor. And they only have to do 90 hours in 6 months, which is half a day a week for 6 months. It's not complicated, and it doesn't. And they're not teaching us they're not teaching us what to prescribe. It's all about how to actually do a consultation. So I'm quite happy to learn that. But that's the biggest problem. And I've asked various GPs, and the pharmacy that I'm attached to has got 12 doctors in there, but trying to get somebody who will actually sign up and do it. So if the one thing you could do is actually provide mentors, that would actually, how many GP surgeries are there in Shropshire, Telford and Foregate?
51.
There's 51. So if you delivered in 6 months and you delivered 51 community pharmacy prescribers, I'll tell you now, that will make a hell of a difference with how and take so much pressure off the GPs. The other thing is I'll finish now, okay, because I know it's tight on time. I'm doing COVID jabs at the moment. People are being invited for pneumonia vaccinations. Pneumonia vaccinations, big thing, as you appreciate. Now, if that was transferred as a commission service to the community pharmacies, we could make a huge difference just at the right time, in the autumn, over the winter, and help to take the pressure off. Okay?
Thank you. Did you want to say anything?
I'm not going to disagree with anything that my colleague has said. I have made a note about the mentoring, because I think there's probably something we can do to support that and reflect that in the plan. It's interesting because I was the second cohort of independent prescribers, and I went into management because I couldn't get any clinical work. So it's really interesting to see the other end of that. I might need a little bit of clinical brush up. I think it's just really, really helpful just to kind of get into the nitty gritty and hear, you know, what really matters, because we have to write a plan in a certain way, and we try and be everything to all people, and we can't. But some of these things are real good nuggets of information that can really, really make a difference. And I know from Dag, we had a bit of a conversation around the development of the dementia strategy that sits underneath. That wasn't actually listed as a priority. It is a priority in the plan on the page, and that was feedback directly from the Health and Wellbeing Board. So we are trying to, well, I'm writing the plan, I've got oversight of it, really trying to capture this, and then make sure that those individuals that are leading in those areas, whether it be community pharmacy or a clinical service, that actually they're capturing it within their strategies and the plans that they're developing for delivery. And very rightly, as you suggest, we've got to make sure that the funding sits underneath it. And if I could just explain what we're trying to do, what we're going to do in the next iteration, ready for the end of June, is talk about the actions that we need to deliver in year 1 and year 2. Some of that is around recovery. Some of that is around standing still and our sustainability for next year. And then we're going to identify the ambitions that we want for years 3 to 5, so that as we move forward and refresh the plan, you can see where the actions have been delivered or are being delivered, and the ambitions then move into actions, and then we add further ambitions depending on what we've achieved during that year, so that actually we can start and monitor and scrutinise the plan, and have that oversight of actually what are we delivering and what impacts is it having on people, and so that they can start and see that actually we're starting to deliver some better care and kind of come out of the pre-COVID and the post-COVID challenges that we've had.
Thank you, Claire. Could we go to Derek?
Thank you, Chair. You know, the problem I have is that for the God knows how many years, and I know Doug's been here, is listening to the plans that are being made that now sit mouldering on somebody's shelf with about 16 inches of dust still on it, but never been reenacted and never been taken. And especially in the last 4 years, we've heard so much that it was going to happen and should have happened, but never did. Now we got fairly excited when we looked at the doctor's one down at Ebenvale. What was it called again? That's Thorntonville. Yeah, we got really excited because it seemed to be something that was so simple and so transferable and so workable, and it was bringing really good results, and it was being acknowledged everywhere. Now we in Telford and Wrekin and in Shropshire have got massive problems trying to talk to our doctors in every short pharmacy, and it got better for a couple of minutes, but now it's gone back to where it was, and they can't access it. We've got to find ways of actually getting patients listened to, and some of the time that's all it takes, a little bit of friendly advice. And the government was talking about putting it, utilising and appraising the community pharmacists, and all of that was going to be a great new plan, how we can actually start getting people treated at the earliest possible time. And that's what we need. We don't need them to go and wait until they're so damned injured that they have to go in the hospital or accident emergency. We want the first being looked at as early as possible, getting the first diagnosis and the treatment started as quickly as possible. And yet we will sit here, and I'll guarantee we'll sit here next year and you'll come back and say, yeah, we've still got these plans and we're going to be doing this and we're going to be doing that. And quite frankly, we get rather frustrated. You're a very small organisation, and you're one of the smallest in the country, and you're going to struggle for finance. There's no question in my mind to do that. And we really need to see some short-term wins in order for us to see and give us a confidence that the plans that you're putting before us are working. Now, that's the problem we have. And what we need to do is say, look, we have got people who are out there day in, day out, 6 days a week. That's a pharmacist. We should be damn well utilising them. We tried an experiment, it's the CCG. They said, look, you can get these prescriptions from your pharmacist. You don't have to bother your doctor. But then they didn't tell anybody. And when I went to one pharmacist, I said, I was talking to them, and they said, we can't really show you the list. Why not? There's no point in putting these plans and things out unless you're going to talk to the public. And quite frankly, that is where I think it's been so quiet. You've been sitting, the organisation's now been sitting there for about 2.5, 3 years. They've hardly talked to us, and we're the scrutineers. We've hardly had any communication until we start making threats. And that's not what we should be about. It is about a mutual partnership. We're not here as enemies. We're here to try and say, look, this is what we see as the problems, is the ordinary lay planters. We're not the experts, but we can have an input. As can the chemists, as can the pharmacists, as can everyone else, and sit there and talk together. Because the problem is not yours. It's all our problems, and we have to be working together. So we just want a much more openness and a more friendly, but also, look, for God's sake, if you see something working, let's not go and invent the wheel. It's working, let's try it. How it's tried, I don't know. We've talked about the PCNs as well, the primary care networks. And basically, they've had all these little things that they could do. But the news comes back to us is because our pharmacists, our doctor surgery used to be able to supply so much. It was drugs and all the rest, drug advice, all the rest of it. And the PCNs, and it was too expensive for one. So it was about sharing it. And the PCNs were giving this extra money. And what we ended up finding out, it ended up that one surgery was benefiting for it. And that was the surgery that was putting it forward. They were getting the extra money to do it. But it didn't help the primary care network. And that was the object of it. Not having to pay for these services all by themselves, but actually making sure it was shared among the community. But it didn't work. Now, and then we found out, okay, who's looking at it? Who's supervising? Who's watching it? Who's actually monitoring this? And there was hardly any monitoring done at all. It was a case of, here's the money, go and do it. And it's forgotten. That can't happen. If money is given out of the public purse to actually do these schemes, let's see how they work. Let's find out what the pitfalls are, and let's make sure that we can actually make sure a system is going that is working for everybody. Sorry.
Thanks, Derek. If you want to respond.
Yeah, I think first of all, I'd say I think we are trying to sit down and talk and discuss some of these issues, and certainly through the big conversation, through the Health and Wellbeing Board, through the Integrated Care Partnership and the workshops, we are trying to develop these plans to take them forward. We're always looking at different ways of kind of, if there's more sitting down that we need to do, particularly with elected members around it, then absolutely. We haven't quite done 1 year as an ICB, and that is a challenge because we've gone through a couple of transformations, which has been challenging coming out of the back of the pandemic as well. So, trying to get these plans together and talk to people and then try and do the engagement work as well. It's not easy, but we're trying to really get out a lot more than we were. The bit around the primary care access, again, I'd probably go back to get primary care. I know they've been to Scrutiny before, but I think with the new recovery plan and the discussion we've had today about community pharmacy and actually some of the issues around primary care access and telephony, I think it would be really useful for you to hear the more detailed plans rather than the broader sort of high level plans that I've got within the Joint Forward plan. And then the last thing to say around the primary care networks, the primary care direct enhanced service is nationally driven. It's not done locally. We have very little wriggle room, and we took a agreement around the primary care networks to not make reporting onerous through the pandemic, and then when we had the Strep A last winter. But they are having to do plans, and we do monitor the spending of the money. There's a monthly meeting to monitor it. So again, the primary care team will be able to give you all the information about how that's happening and what's happening and how we do monitor it. And the way primary care networks are set up and how they sort of monitor their own governance and make those decisions within the networks, they could sort of talk to you and explain how that works.
Here, can I just bring one example? The virtual wards. We talked to Teldoc, one of the biggest organisations in primary care. And we said, tell us about how you're interacting with the virtual wards. And they didn't. They said, well, we hardly know anything about it. Now, if you're going to introduce that type of system, you know, without primary care there, backing you up and being a major part player in this, then how on earth is it going to work? And I believe there's real opportunities with the virtual ward, because everybody doesn't have to be in hospital.
Well, virtual ward is not supposed to be linked too strongly to primary care. It is supposed to be managed by secondary care clinicians. That's why it's a virtual ward. And there are discussions ongoing between primary care, because it's the community trust that are operating the virtual ward, because it's around appropriate discharge and management of patients in their own homes, as you'll be aware. But it is not necessarily the correct place for primary care general practitioners.
Should they not be informed? Because they are the people there 24/7, like, you know. I don't. You tell me, should they not be a part of it?
They are. Well, they are part of the discussions through the GP board.
Thank you. Can we go to Hilary?
That's it. I think Derek has said some of it, but I would like to reiterate that we were so impressed when we looked at primary care and Taunton Vale, who gave up the lead GP from Taunton Vale, gave up a chunk of his time to talk to us about how they operate their systems. I think we have passed that knowledge on, but I'm not sure I would like some reassurance that it's at least being looked at, because as Derek said, that would be quite an easy win, we think, for improving access to GP services. And I'd just like to know that it's being taken forward in some way.
So again, that's a question you need to ask from the primary care team. Just to point out that GP practices are independent contractors, and their models are their decision. And as much as we present lots of different models of care, and I have no idea where the Taunton Vale, I'm aware of the Taunton Vale model, where that has got to with discussions with the primary care team and the practices. So I can go and find out and feed that back as part of the questions. And then I would suggest that we talk to the primary care team.
Sorry, Chair, can I ask our officers what joy they had when they were trying to contact primary care, of trying to get them into a meeting, because they spent many hours trying to organise meetings with primary care. Can we just ask our officers how they were responded to?
Well, I guess we can answer from a Shropshire perspective, but I think you might want to also think about it from the Telford perspective, because each authority has looked at those separately and individually as well. Certainly, from a Shropshire perspective, it was probably more focused on the piece of work that was done in the Task and Finish group last autumn, which was looking at the ambulance response times initially, then looked at primary care and across the piece. Probably less direct as a request, I think, Derek, than maybe you had in Telford and Wrekin, in terms of involvement of primary care and impact, certainly from the perspective of the health and well-being hub in Shrewsbury, which has probably been the most recent focus around primary care. That's been fairly positive, but that's been through the ICB. board, so Gareth and Emma, and so it probably a slightly different level of focus from the Shropshire experience.
Yeah, I can echo what Tom says from the Telford point of view. We've dealt with the system-wide, and we've had some difficulties in the past, and trying to get officers to speak, and this more in relation to our GP primary care access task and finish group we've had at Telford Domain Council.
I'll speak to Gareth, who's the exec lead for primary care, and see what we can do to support that. If you just tell us what the ask is and exactly what you want. I know some of that's been described now, but we can pick that up.
Thank you. We'll go to Kate. I will come to you after Doug. Okay.
Yeah, thank you. Going back to the primary care recovery plan, they had a few key themes, and digital was one of them, and community pharmacy was another, and another was issues between transfer from secondary care from hospitals to primary care, GPs in particular, and how there's quite a number of issues there, aren't there, in terms of people transferring, people being discharged from hospital and then it being left to primary care to refer to different services, etc. And so I guess it was a comment just because I do see this plan as quite important, the recovery plan, and as I understand it, it's been pretty well received by different leaders, RCGP, etc. But with the caveat that money needs to follow it. But I just wonder whether something could, the way the report, I guess it's the general thought about the report, the way it's laid out, and I can understand why you've done it, is that we've got hospitals, then primary care, then the community pharmacy, and I can't see anything about for example, in the planning about improving transfer from hospital to community, and you do quite a big thing going on in the hospitals at the moment, so I can understand why you're focusing on the hospital transformation plan. But I guess in general, just something perhaps a little, there's a bit at the beginning talking about how there's going to be integration, but perhaps some of that could be built directly into some of the actual planning, because it's not clear here that it's happening. And then the other thing I'm really surprised here about the wait for non-medical prescribers courses for you, and I understand the reasons why, but I just wonder if you're looking at a piece of work, if you go to both Telford or Shropshire drug and alcohol teams, they provide a good model, because in that sector, which is the sector I've worked in, nearly all the prescribing now done in those teams is done by non-medical prescribers, and I'm guessing that they get their team doctors to mentor, because it makes sense. But they're on site, etc. It'll be part of their contracts. But I'm just thinking that might be an interesting model for you to take a look at.
Thank you. That's a really helpful point, and I have written it down so that we'll make sure that we bring that out better in the plan. There are some technicalities around the competency that you train and do your mentorship on. So for many community pharmacists, just focusing on drug and alcohol might be helpful, but some it won't be. It needs to be broader than that. So, but we'll have a look at that. I'll take away that whole mentorship thing anyway and have a look at where the different options are.
Yeah, I mean the thing is that we're not looking to prescribe for diabetes or heart or blood pressure or anything like that. It is the minor ailments and it's minor infection and that type of thing. So it doesn't need to be a very complicated thing, but it would just give us the freedom to actually really take a huge chunk of the workload that inadvertently gets directed to A&E, because lots of people, they say to me, well, the only way I can be seen by somebody today is to go to A&E. I'm quite happy to wait for 7 hours or what have you, which is totally unnecessary. And ditto for the GPs. Let's take the pressure off them. Sorry.
Do you want to respond, Claire? No, happy. Okay, Dan.
Just to come back on something Claire said about all practices are different. I did spend some years overseeing all the GP practices in Shropshire, Telford and Wrekin, and some of them would have been resistant to change, but a lot of them, if you gave them a model that might improve how their services operated, some would bite their hand off. I do accept that the Taunton Vale model, if you looked at it, and I hope you looked at it, and you haven't told me if you have, I think you probably don't know, but it would require a movement of resources. But the outcome appears, and I say appears, you need to look at it very closely, appears to give a much better service for patients and a much better operating system for the GP and their staff. Can I move on to a couple of other things? I've got time to, thank you. The virtual ward, I was going to mention about virtual ward. I think the Community Trust are having major problems of recruiting, aren't they? And the virtual ward would depend upon some input from that area. So is there anything that you're able to do that's going to improve the position, the nursing position of the Community Trust, or is that something that's beyond ability? That's one question. Move on. I'm dying for someone to, if you look at page 51 and the last box, I'm not suggesting that you do this now, Claire. I'd love someone to translate what it says. You have a look at it, page 51, the last box. And see if you can work out what it means. Can I move on to bowel cancer and cervical cancer screening? There was a statement, I think, page 53, about reducing the health inequalities. It didn't indicate what the inequalities about bowel cancer and cervical screening. Is it a geographically based, or is it use the old term social class based? That's another comment. Anyway, move on. Page 55 had the very interesting comment of the ambition is to be average. I didn't think that was a terribly good ambition. But if you see on page 55, you'll see that we are below the national average, and the ambition is to become average. I'd rather hope the ambition is to be above average, really.
So it's got to be.
Thank you. Sorry. And I was going to acknowledge that the issue of dementia has been added as a priority, and bearing in mind the ageing population, the growing population, I can acknowledge that. I think that's a very positive thing, and thank you for that.
Yeah, Claire, if you'd like to respond.
I've just made a note of the pages so that I can go and just double check that they're not typos. I'd agree that we want to be above average. We should always be striving for excellence. So, yeah.
Thank you. Louise, did you indicate you wanted to speak?
Yeah, just then one final point. You mentioned in the report about the programme of work and how, Shrewsbury and Telford hospitals are going to be specialising in different fields going forward, and that this will deliver reduced travel. Now, is this reduced travel for the hospital staff? Because I can't see how it's going to reduce travel for the patients. For instance, people in my community, in order to get to a Telford hospital, it's 2 buses plus 2 train journeys each way.
I'll have to double check that point, because I think it's not either of those things. I think it's about where the clinicians are based, so like from a clinical perspective, as opposed to travel for patients. So it's the specialties that are centred in the individual trusts. Because actually, if you take travel, for example, a lot of services go to Stoke because they're specialists. So I'll just go and check and clarify that point.
If we haven't seen today's Shropshire Star, the Prime Minister has written to Shropshire saying additional money is going to be made available to facilitate the hospital transformation programme.
Thank you, Simon.
Thank you very much. Simon Fogel from Healthwatch, Telford and Wrekin. I've read through the plan a few times, and I think it's great when it starts at the beginning in Sunir Mackay's intro, in that the focus must be on people and place. and that our health and care services will work in partnership with people in our communities to shape a person-centred, integrated and life course approach to preventing and living with ill health. Laudable. And then it carries on in summary at the very beginning to engage with our communities to co-produce solutions and blah, blah, blah. And it's based on engagement with local communities. There's very little then within the narrative where I can see any of the actions that are planned are about what you told us we're going to do. That there's so little reference of what actually is coming from communities themselves. And I just think this is a trick that you're missing, because if we want people to engage with this and work with the system to produce better care pathways, often that will result in change that people will be resistant to. If we, as the purveyors of this, who are going to promote it on your behalf, can't say in the actual overall document that sits on Councillor White's shelf gathering dust, look, at the very beginning, your input shaped this plan through the system, listening to your point of view, reference A, B, C, D. It's not there, I don't think, and I think it could be.
I said at the beginning, Simon, that we haven't pulled all the engagement work through into the plan. And actually, although when the first draft was done, we'd only done those big conversation events, we're actually doing the going out to the seldom heard communities, mental health, particular groups, and then we've given a commitment to make sure that it's really clear through the plan that you said we did, even if we can't do something, why we can't do it, how we're shaping it. When we had to submit to NHS England on the 22nd of May, we've still got sort of 5-6 weeks before final publication. So you're seeing a version at a point in time, and what changes within a week is huge. I mean, it's changed even since the version that you've got now. So some of the points are already coming through.
Is any of the plan actually based on resident feedback so far?
Yes.
It would be really good to see that, even in this draft form, else it would save me sitting here, making myself look like a fool.
So, for example, the children and young people's section, I personally went and had a conversation with parents and carers, other people that are involved with children's services and safeguarding services, just to make sure that we captured some of the needs. So, for example, things that we've done through a system-wide look at complex children's needs to make sure that mental health support for the families and carers was captured within the plan, particularly around some of the mental health sections, just making sure that we got some of those service user feedback within the plan. We've got some work to do around putting in things like the how we use our hospital buildings, around the services that we deliver in some of our more rural communities. We've talked to, I know that they're going out to sort of some of the older age groups and things like that. So some of that isn't in the plan yet, but it will be referenced in the plan. So some of it is there. I think the point that you're making, that we make it more explicit in the plan, I think is helpful. And we will try and do that to draw it out so it's really, really clear where we've had engagement and where that's influenced the plan.
Thank you. Thank you.
Thank you. Are there any of the members that would like to put questions to Claire?
Not a member, but it's not so much a question to Claire. It's an observation and maybe a query to the members as well. And then obviously it would be interesting to get Claire's view as well as the members' view on this. Having listened to that conversation take place there, and I think it's safe to say some challenge, but also I'm hoping I've got it right, Claire, some added value from what's been shared. I guess there's a couple of questions for me in this. One is, would there be value, would members of this committee be interested in acting as a sounding board and would the ICB find it helpful to have members acting as a bit of a sounding board to do some of what you've been doing today, but do it in a more ongoing basis rather than I don't know, Claire or someone else comes along and enjoys the meeting, but it's
enjoys. Did you say?
I did. Yeah, I chose my words carefully. I'm trying to think of a way to make the process move along at a pace which adds value rather than it being a delay. Sorry, Claire.
I think it would be incredibly helpful, actually. So the richness of the detail of the discussion that I don't always have the answers to. What I don't want this plan to be is, as Councillor White suggested, a tome that sits on a shelf that gathers dust. It needs to be our plan for the future that our public can see where the difference is being made and the impact that it's having, recognising the challenges that we have about recruiting and retaining workforce, and how that links to our other plans and our financial challenges. Because if we can get into financial balance, we can start to really do the transformation and really make the difference. We can really start and get into the prevention. We can really get into the proactive care. We can really keep people well at home for longer. We can really make sure that they don't go towards A&E. That's the dream, isn't it, really, to make sure that we do that. I would really welcome the chance to, and I've learned lessons from doing, sort of town councils and what have you, the value that elected members have in being the sounding boards, and because you hear from your constituents what's happening on the ground, it's really helpful. We hear from patients, but that's only one cohort. I'm not a patient, I'm a person that lives in Shropshire. So my interaction with services might be just through my GP. So to get that richness, I think would be really, really helpful as we develop the plan. I don't want the development of the plan to stop on the 30th of June. I want it to carry on so that we can demonstrate where we're delivering the actions and actually extending our ambitions as we work through some of those workforce and financial challenges. So that would be my bit.
Lynn?
Just a couple of points from me regarding that. I think it's important to remember that the Integrated Care Partnership, which is led by the two leaders of the councils, is responsible for authorising and approving this plan. So there is that high level relationship that I think you just need to feed into as well, rather than it necessarily being everyone and everybody, because there is that mechanism, isn't there, for that regular discussion. So maybe there's something about each council having these conversations and then feeding in, and maybe that would be more manageable. That's just a thought of mine, into, because I do think we've got to recognise that the Integrated Care Partnership, which is represented by the two directors of public health and the two leaders of the councils, ensure that both places have their voice heard at that level. So I just wanted to throw that into the mix. The other thing I was just going to add as well is that because Healthwatch Shropshire and me namely have been going to all of the big conversations in Shropshire, I can confirm that the feedback that I've seen and heard in those meetings has been shared with Claire, and therefore it is being integrated into this plan. So even though there aren't those clear descriptions at the moment, I do know that that is a process that is taking place. I think that was the main thing I wanted to say.
Doug?
To make one comment on digital matters, the number of elements of digital development within the NHS. I mean, heavens above, how long ago is it that they stopped using fax machines? And you referred to the electronic patient record. I think Noah started talking about that, didn't he, already? Noah? Start talking the electronic patient record. I mean, the NHS really has to work very hard on. Sorry.
I think it was Adam.
Yes, has to work very hard on that area within the NHS. But on the other side of it, in terms of digital exclusion, couldn't leave a meeting like this without saying that many older people don't have access to the sort of things that we normally expect. I mean, so sometimes if you go to a car park, you have to have a mobile phone with a key reader. A lot of older people don't have those sort of systems. And also, the picture seems to be growing with the cost of living problem that a number of the poorer families are now giving up on mobile phones. So we've got to just be aware there are chunks of population which don't have the same access to digital services that we probably think are routine.
Thank you. Would any members like to ask any further questions? No. Claire, would you like to make any comments before we move to the next item?
Just to say thank you. It's just been very, very helpful. And actually Lynn's comment about the integrated care partnership, I know Rachel, Liz Noakes and I've been in conversation about how we develop that and sort of conversation. So it might be something for us to take away and think about.
Thank you very much. Okay, moving to item 5, Lynn Corley is going to tell us about the report calling for an ambulance in an emergency.
Just to check while I find my presentation, if anyone wants to get a glass of water, then that's fine. Will I share my screen? No, that's fine. So I have seen this presentation at the Health and Wellbeing Board, so
Joe, do you mind if I disappear?
Yeah, that's fine. Thank you for coming.
So I believe that in your papers you've got the whole report, and I've just I'm bringing a presentation that went to the Shropshire Health and Wellbeing Board that just summarises some of the points from this presentation. I think it is really worth drawing everyone's attention to the time scale of this report. So this was done from June to September last year, and it was at a time when ambulance delays were in the media. It was a time when a lot of people locally were talking about it, and it's also a time when there was a couple of meetings with our local MPs who were also wanting to know what was being done to address this situation. And Simon Vogel from Healthwatch Telford and Wrekin is here today, but it is important to say that as the new provider of Healthwatch Telford and Wrekin, engaging communities were not part of this piece of work. So any questions you've got are probably best directed to me. And also you will see that this is very much from the Healthwatch Shropshire perspective, because it was the understanding that Healthwatch Telford and Wrekin would take their own report to the Telford and Wrekin Health and Wellbeing Board. Okay, so I'm just going to skim through some of this, but why did we do it? I've mentioned those national and local concerns, and at that time Rachel we can blame Rachel spoke to Healthwatch Shropshire to ask if both of the Healthwatch would consider doing a piece of work to get the public experience, because there was a lot of data available across this system at the time from all parts of the system and providers, but that lived experience, that the personal stories were missing from that, and it felt that they might bring a really powerful perspective that might promote some sort of radical action to try to address the challenges. It was reiterated time and again at the time that it's a complex issue, and therefore there would need to be a system response in order to address it. So we looked very broadly at this. We wanted to understand the whole patient journey because of that complexity, because otherwise, you know, for example, the ambulance service might say the delay was at the hospital, but the hospital might say it was a delayed discharge. So there was a knock-on effect. So when we asked people to share their views, we wanted to understand their whole journey from the point of phoning for an ambulance, but also if they were taken into hospital, how that process had been for them as well. So we promoted it through all of our usual communication channels, through our contacts, press releases, social media, but also through face-to-face engagement. And we also made sure that all of the patient groups and the people supporting patients knew about it, and obviously raised it with our local councillors. I went on Radio Shropshire to talk about it, and several articles appeared in the Shropshire Star because it was such a national and local issue. So we know that online surveys can prevent a lot of people from participating. So at Healthwatch Shropshire, we've also got a free post address where we ask people to share their experiences and comments, but we also have always encouraged people to give us a call and we will help them to fill in any survey online. So we heard from 168 people altogether, and 160 of those were from Shropshire. And I just wanted to pick up on the fact that although 8 were from Healthwatch Telford and Wrekin's work on this, I don't think that that is indicative of the scale of this problem. My family and I are from Telford and Wrekin, and I know that it is an issue everywhere. And I think it's simply down to team capacity and size that we may have promoted it more widely than Healthwatch Telford and Wrekin did at the time. So we found out where people were talking to us from, and we heard from patients themselves, relatives and carers, and also professionals. Because one of the things I really wanted to do was to hear about, for example, the experiences of care homes who were calling on behalf of residents or domiciliary care workers. And fortunately, some of those did get in touch with us. So in terms of timing, 103 of these occurred between October 2021 and September 2022, and 53 didn't include any date. And the map there is obviously much bigger in the report, but it does indicate where those people were who contacted us. 74 people included their postcodes, so we could identify exactly where they were. And in this diagram, it shows the larger the bubble, and particularly if it's pink, shows the negativity. So you can see that those experiences are quite well spread across the county. So it's not surprising to see that the majority of negative experiences were around waiting times, but we also heard about people's experiences of the triage process, both with the ambulance service, but also once they got into the hospital. And the most positive experiences were actually about the quality of staffing. And it's really important to us at Healthwatch to be able to pull out where things are working well for people, because, you know, we knew that this was a massive challenge across our system, but there's also a lot of people working very hard to try to serve people and to do their jobs well. So we really wanted to highlight that as much as possible. The issues around communication were largely around communication between the ambulance service and people who'd placed the call. So I've given here an example of the positive comments, which were largely about the ambulance crews, who by and large also shared their frustrations, particularly at how long it might have taken them to arrive, which I think sometimes professionals think is helpful to patients, but actually people don't really care why you've taken so long, because that's not their problem. They want you there when they need you. So I've pulled out some of the negative comments. I think one of the ones that made the biggest impact at the time was the one on the right about falls. So this person said, we've been directed that we should not be trying to get people to stand up, and that our first port of call is to call for an ambulance. We are not trained or qualified to assess for any serious injuries beyond regular first aid. And this was actually a learning disability support provider in the community. And so I escalated this to Shropshire Council to say, are you aware of this issue? Can you help? And they did commit to liaising between the ambulance service and the providers involved. But also when I was sharing our findings, this was before the report was published, that it was picked up at the Shropshire Integrated Place Partnership Board, and immediately work was undertaken to develop a falls pathway in Shropshire, because there was one in Telford and Wrekin at the time, but there wasn't one in Shropshire. So a lot of the subsequent work has been around falls, and that's led to the project that's been happened recently to pilot an approach where another service goes into the community to help people who've fallen, and that has worked really well, but the issue is how they're going to fund that to ensure that it continues. So other things were about triage. The decision not to send an ambulance immediately was because it was a fall, would it have been a difference if I'd said collapsed? So people felt that that what they were saying was either being misinterpreted at times, or the severity of it wasn't being accepted, and that led to quite a lot of frustration and impatience. We heard about people having to make their own travel arrangements. So some people said if we'd have been told how long we would have waited, we would have made a decision to transport them ourselves, and this might have improved their outcome. So there was a lot of people who felt quite guilty that they hadn't been more proactive, and they felt that they should have been advised to do that. And that is clear in the report. So in terms of quite a number of the comments about falls in particular talked about dignity and distress of the people who were left lying in their own urine and faeces, the indignity and discomfort. But also we know that if someone is left in one position for any length of time, that can impact on their long-term outcome. So we've highlighted that again throughout the report. My approach to these reports is that at times our reports are long because we have a lot of comments, but I think every comment that is shared with Healthwatch Shropshire is valuable. I am not the person who says that that one is more powerful or more important than another. Sometimes we deal with that by putting them all in an appendix as well, but we do make sure that they're all included because everyone who's taken the time to share their experience with us has the right for their voice to be heard. So I pulled out 2 case studies. So this one was from about a lady who died, unfortunately. So she'd been in a residential home in the dementia unit, and she was discovered by a care worker at 5 a.m. with a suspected broken hip, and she was lying on the floor in a lot of pain, and of course no one was able to move her. The first call was made at 5:18. The home then made 5 999 calls, and the clinician called back at 10:23 in the morning. But this lady unfortunately went for 16 hours before the ambulance arrived. The second one, our GP phoned for an ambulance for my husband at noon, and it didn't arrive until 8:30, 2 days later. If we'd known that they would take such a long time, then we would have transported him there ourselves. He was kept waiting in an ambulance on arrival, even though he was in so much pain. And within an hour of arriving at the hospital, that gentleman was diagnosed with terminal cancer and died shortly afterwards. So when I went to admittedly, it is quite a new integrated care system, but I'd hoped, because I'm very optimistic about the integrated care system, that I would be able to get an integrated care system response to the report. But it turned out as time went on that this was going to take a long time. And also, I just decided we couldn't wait any longer to publish. So I ended up going to each of the individual providers for a response. The response here was from the Chief Medical Officer at the Integrated Care Board, otherwise known as NHS Shropshire, Telford and Wrekin, where he describes the complexity of it, but also the need for the system to take a holistic approach and for them all to work together to understand the challenges. So, in the full report, you will see a number of pages where they itemise all the things that they've done to try to address this challenge. And I think it's not going to be until this winter that we find out if these are actually working. So, for example, some of it involved multi-agency working. So they'd set up a winter control room where they were using multi-agency data to respond to pressures across health and care services to make sure where there were gaps, there were services going in to try to cover those things. They've created ambulance decision areas at both hospitals to help with the communication between paramedics and the emergency department staff. And that includes, I think, having paramedics working within the emergency departments so that even if the department won't accept a patient, then they can be handed over to the paramedic in charge until the hospital can take over. there has been rapid response teams created, where the ambulance service and community partners have been working together to try to ensure that only people who need to be transported to hospital are taken to hospital. And so that also includes help from social care. Same-day emergency centres in South and urgent treatment centres to try to divert other people away from the emergency department so that they could try and prioritise those 999 calls. And then, of course, they also introduced 111 first last autumn as well, to try to encourage as many people as possible to phone 111 before they phone 999 to see if there was other places that person could be directed to. They started talking about virtual wards, and at the time, I think because of they were new, they were acting mostly as a step up, as a step down provision rather than a step up provision. And I believe that balance has now shifted. And they also had nursing and therapy in-reach teams to try to go into care homes to help people to come out of hospital as soon as possible. The Hospital Trust talked to us about their acute assessment floor, how they tried to increase capacity in the emergency department, and what they'd done to try and improve patient flow to help ensure people were discharged in a more timely fashion, and how they were having to create new bed space for patients, which were probably, I think it's fair to say, in spaces where they'd previously been told they shouldn't have beds, but they were having to add extra beds to try to deal with demand at that time. Primary care talked about their extended access appointments and trying to expand that across each of the primary care networks. The Community Health Trust talked to us about the work they were doing on virtual wards and the work that they were doing going into care homes to try to support the staff there. One of the things I was already aware of because of going to some of the mental health meetings was the work to develop a 24/7 all-age mental health helpline and crisis teams. The work being done in the community with calm cafes to try to reduce the need for people to need to go into A&A by de-escalating sooner. Support from the voluntary and community sector to support people again in the community, and in-reach staff from mental health into the hospitals. So at that time, there was a lot of support from the Mental Health Trust going into staff, and now they have set up their own mental health team, including psychologists, to support patients and staff. So the response culminated in this what they called 3 pillars: community-based initiatives to better support people in their own homes, that includes virtual wards, changes to processes and systems that improve the patient journey through the hospital, and improve discharge out of hospital and community and social care support. Now, I think it's fair to say that they haven't managed to make all this work as well as they want to at the moment. One of the things that I'm not sure has started yet, for example, is that I know that the system committed to offer some financial input into a new service where the ambulance service is going to provide a number of ambulances specifically for people with serious mental illness. So locally, we've contributed to that. Those ambulances will be staffed by paramedics with specific mental health training, with the backup of the necessary psychological services and consultants in order to try to take the pressure off the regular ambulance service. So Healthwatch England, because this is such a national issue, obviously picked up on the concerns that we were having locally. And also what I've explained here is it's important to recognise that Healthwatch England is a statutory committee of the Care Quality Commission. So when people share their views with us, and we then share them with Healthwatch England, they're actually seen at a much higher level and shared with the policymakers across Parliament. So what happened was Health Watch England used some of the evidence we provided in a report to the House of Lords, highlighting the national emergency care crisis. At the time, Health Watch England recommended that the government declare a national emergency and refer this situation to the Cobra Committee. Unfortunately, that recommendation wasn't followed. But I think it was helpful to note that the Health Watch evidence included in that report was one of the stories that we'd shared about a lady who'd been left on a kitchen floor for 21 hours after her daughter called for an ambulance. And so the Lord's report called for obviously more input from staff, but also closer reporting on the issues and the challenges, and action to address the broken model for primary and community care that, you know, is likely to drive some of these patients, as we heard earlier, to seek help from the acute hospital. And that is the end of that presentation.
Thank you very much for that. And would any members like to make any comments or ask any questions? Doug?
Maybe just to ask Lynn, when you think the next, when you think you need to look at it again to see what's changed? 12 months, 2 years?
Well, I think the value of taking it to the Health and Wellbeing Board, and this is certainly what happened at the Shropshire Health and Wellbeing Board, was, you know, both Health Watch are small. We're small organisations with a large remit to cover the whole of health and social care. And for me, it is the responsibility of the system to demonstrate that all the actions they've told us about are actually working. Because yes, we can go out and gather people's experiences, but we'll never hear from everybody. And yes, we can do it again, but I think it has to go alongside that feedback from the system, where they report on the impact that the money that's being spent has had, what is going to continue this winter, any new things they're going to do this winter to make sure that we don't have that same situation happen again. So while Health Watch Shropshire, I can't speak for Telford and Wrekin, would be happy to go for it again, I'd need some reassurance that the situation has changed and improved before we did that.
Thank you, Kate.
Yeah, just a quick couple of comments. Really good report. One comment is it's just really nice to see and hear the direct impact that your feedback, in particular on Falls, for example, had in terms of shaping local services. So that's just, it's good to hear. And also it's just interesting seeing this, isn't it? People have a real right to feel very upset and angry about the situation with the long waits in ambulances. But so much of it ties back into what we were, as you made the point you made at the end, ties back into what we were talking about. You know, unless we get primary care right, unless, you know, the other parts of the system are working well, this problem is likely to persist. But yeah, just to say thanks for that report.
I think it's worth noting that when I shared this report at SHIP, and of course Telford and Wrekin have got TWIP, what was really interesting to me as someone who's independent of this system in a way, was that GPs at SHIP weren't aware of some of the services provided by Shropshire Council. So they weren't aware of 2 carers in a car. And so I think that does highlight the value of those meetings. I think someone talked before about communication. If some of these things are going to work and work well, there has to be better communication between all parts of the system so everyone knows what everyone's doing. And what I think SHIP revealed was that hadn't happened.
Thank you, Derek.
Thank you for that. Yes, then, if I'm really honest, this really rings bells back to when Shropshire lost its ambulance service and was amalgamated with the West Midlands, and the promises that was made then to us. New ambulances, each ambulance would have a paramedic who was trained up to just below doctor standard, who could actually say to patients as they came, I'm sorry, you shouldn't be going here, you should be going there. And it has never, ever happened. They were also going to have stations in Shropshire, Telford and Wrekin, where the ambulance would be waiting there, so it was close to the patient. And within 12 months, we were hearing there wasn't an ambulance in Shropshire at times, which makes it really think it's so continual. And that's why we need to check up on these things. We need to go back and find out and say, look, enough's enough. We've heard your word, we've heard your promises, as we've heard today on other areas. We need to go back and say, look, we need, and it shouldn't just be left to Health Watch. That's what we're here for. That's what the scrutiny. And we can actually, and we need to actually, when we've got investigations, to go back after a reasonable period and say, show me what you've done. Tell us what you've done. And by what, I mean, the idea is that we work together, Health Watch and Scrutiny. And we need to actually start that process, start afresh. And let's go from there and saying, look, and we can be calling these officers in, and we've got the reports that have been given to us, we've got the promises they made. Now tell us how you've done it.
No, yeah, I welcome that.
I wonder why Telford and Wrekin Council didn't respond. I know it was a small issue, but surprising that the Telford and Wrekin Council didn't give a response, given the extensive response from Shropshire.
I suspect it was probably the quantity issue, but it might also have been that Health Watch Shropshire asked. Because I did ask Health Watch Telford and Wrekin at the time to ask, but I'm not sure if that happened. So I'm not sure why that reason. But what I've always said is that if they did choose to respond, I would add it to the report at a later date, so that there is still an open door for that to happen.
They've at least said thank you, couldn't they?
Yeah, I was just going to pick up on what Derek said. There's, while we were doing this and I was going out to parts of Shropshire, including places like Ludlow, for example, people there were also talking about the fact that would it be better for us to have our own ambulance service again? And the message from the system was it's not a financial viability, really. But also a lot of people are under the impression that having an ambulance station in their local area means they'll get an ambulance more easily. But in this particular situation, because there just weren't enough ambulances, there was no ambulances sitting in any stations, because my parents live opposite the station in Donington, and where there's about 10 ambulances, but then there's never any there because they're all out all over the place doing different things. So I think that model may have worked, but it would only work now if there was quite a significant increase in ambulance numbers.
I actually go to the hospital quite regular with my brother. He's blind, and I have to take him there and look after him. And they send him there for the most stupid reasons, but they do send him there. And he normally takes an hour and a half. So I get bored and I tat about and I look around. And I always look at A&E. And the last time I was there, about 6 weeks ago, 15 ambulances was outside that A&E. 15. And during the period I came there, there's two ambulances. One was a personal carrier one, and the other one was a proper ambulance, moved out of that station, but two moved in. So it's just, it does not bear belief, the amount of ambulances are just stuck there. And, they used to have a halo. That's a hospital ambulance liaison officer who would take over the patients and would look after them while the ambulance could then depart. But for some reason, it's just completely bogged
Yeah, I'm
down.
not sure that's consistent. Yeah, I thought that had been reintroduced, but I'm not sure how consistent it is.
There you go.
Yeah.
Thank you. So, firstly, as Lynn said, I was very keen that this report got undertaken. It's really important that we put the residents' voice at the centre of everything that we do. We're hearing a lot about numbers and times, and this report really clearly articulates the reality of what was happening for residents. And I think, and as you said, and just to as Councillor White said, I think it's really important that we do bring this back. We've done quite a bit of work. This committee's done quite a bit of work at Health and Wellbeing Board and obviously our ICS to look at examples through the task and finish group of work that we know needs to be done to include to improve the urgent care system. There's been a needs assessment that I know that's been shared, that's been done regionally around activities and the impact more broadly on urgent care, and there's obviously a huge amount of work that is going on in the system, and the actions are here, and we have that plan, but we do need to hold ourselves to account to make sure that that is being delivered, coming back to the resident stories and the impact that this really has on individuals' lives, and to hold that at the heart of what we're doing and make sure that those actions are being followed through, to have that transparency. And I know this committee's done a huge amount of work around that, but I think it's really welcoming to hear that you would want to have that oversight to make sure that is being held to account. That's the important role of scrutiny in all of this. Whilst our health and wellbeing boards are doing a huge amount of work, and then through them our SHIPs and TWIPs, I think it's really welcome that you've received the report and would want to follow, making sure that we do follow through on those actions. So just thank you, and thank you to Health Watch for pulling this independent review together and collating all those resident stories. Really important.
Yeah.
Thank you. Did you?
I guess, and hopefully this will segue really nicely into the work programming item, which is going to be next. I won't steal anyone's thunder, but I guess it's just to say that the work programme that you'll be discussing is very much strongly focused on picking up a series of rolling informal sessions and then the formal sessions, which I know you discussed on Monday. You've got the winter pressures, winter planning, urgent emergency care focus is a very strong feature of that, and I would absolutely, I mean, what Lynn shared there summarised really nicely, I think, a number of the issues, but also the actions which the wider system is looking at to take to address. In this instance, it was waiting for an ambulance, but actually that's, if you look at it across the system, it's all of the things which you'll want to be looking at. So I think you'll start in July, and I think you'll continue to be looking at that throughout the year, and it is the challenge, I think, to the NHS in Shropshire, because we really cannot, by some wood to touch, be in the position again that we found ourselves last year. And I know this committee has asked every year for a number of years for information about the winter pressures and the winter planning and you're always told every year we start it in the summer, and every year you get it in November. When we're in the middle of the winter pressures, which don't stop anymore, and they're all year round. So absolutely, I think you're going to be on this and in a rolling process. And I think, just to echo what Derek and Linda said, there is a really strong symbiotic relationship between the powers of this committee with its ability to call in the NHS, its relationship with its parent councils, and Health Watch's ability to actually go and do the interim view and do that research and bring that objectivity in as well. So it's just really keeping that going. And I think with new support in Telford and Wrekin, it's how you as a committee can work with both Health Watches to get that commonality in terms of the focus, so we have real power across the system as well.
Thank you, Derek.
But there's also a real opportunity for us here, and we have been talking about how we recreate the HOSC and how we work, mainly in workshop type system. And this gives us a real opportunity that we can have the workshops and we can have the health watches involved in that, because there isn't rules set out who we have in there. And that tells us, look, you're the people who've went out there and you've done the graft. We're asking the questions, where are you there? And you've got a real, in your other capacity, you've got a real opportunity saying, no, this is not what you said. This is not what you were going to do this. But there's a real opportunity of making those workshops really powerful, just as we had with the pods, when the parents group came in and destroyed the mental health plan that they put forward. So there's real opportunities for us to use the new technologies we've got there without having to get everybody in their damn rooms. And, it really is really a chance of making great HOSC. Yes.
Thanks, Derek. Would any other members like to say anything or ask a question? No? Lynn, would you like to make any comments before we move to the next item?
I'm just thankful to have the opportunity to bring this to this committee, because I'm aware that, you know, in terms of the time scale, that it might seem a little bit old news, but actually it's one of the reports that we've done that's created the most interest. And I do think it's a really valid report to continue to follow up and make sure that all of those commitments actually come to fruition. So thank you.
Thank you very much for that, Lynn. So item 6, the work programme. I'm now going to ask one of the scrutiny officers to present the programme for the upcoming year.
Thank you, Chair. I'm just going to get the slides. It is only a verbal update, but just thought it would be helpful to be able to have a couple of visuals as well. Here we go. So it did and does follow on perfectly with what we've just been discussing. And what I've included here is just a very simple matrix picture of exactly what's been described and the opportunities that have been described in terms of having the informal meetings then being designed to flow and inform the, you're not saying, I can always share it afterwards, don't worry. But all it says, so the little grey boxes around the outside are the informal sessions, and then the inside of the circle is the dates of the joint HOSC. That's all that's in there. But it's just meant to be a visual representation to show that the richness of the discussions that can be had through the informal sessions, being able to find out more, then means that when you come to hear in the joint HOSC, that having that richer context, more detail, that the discussions can be really, really valuable and provide that really detailed scrutiny. So that's just sort of confirming that approach is continuing with the fortnightly meetings feeding into these sessions. And then in terms of the upcoming sessions themselves, hopefully there shouldn't be any surprises here, because this has all been decided and gathered through the work of the committee so far. Less than a month away now, so the first meeting in June, which is the first blue box there, is the intention to begin that conversation around the winter planning, very much looking at the previous learning from last winter and understanding how that then is going to inform the service provision for next winter. Then moving on to October and looking at the staff performance update, and there it was agreed that we'd be looking at trends in performance, focusing very much on understanding how the Getting to Good programme is progressing, how that's measured, and what are the mechanisms and frameworks that surround and support that to make sure that, you know, what is the progress, how is that progress being made, how is it supported. And then moving on to February, then bringing it to the 5-year plan and understanding further what's been discussed today around the impact of the big conversation and what will happen with those findings. Should already be able to see by then how those have been drawn into the plans and see some of that evidence in terms of the impact that's having that was been discussed earlier. And then the final session planned so far in May at the moment has been left as to be confirmed because of the acknowledgement that it is nearly a year away and just the reality that things can and do change. So it leaves space then, so if something needs to move due to other priorities, there's an allotted space there, but also as new topics emerge, that there's an opportunity that it can be included there as well. So as I say, hopefully that's just a confirmation of what you've been expecting to see and no surprises, but it was just felt that it'd be useful to do this today as a quick recap because we've had that little period of time break whilst the TOEFL elections happened, and also that we've therefore welcomed some new members, which just hopefully make that clear. Thank you.
Thanks for that, Sophie. Would any of the other officers like to say anything on that, or is that? No. All good.
Ollie, we've got new people here that we've never met before. It's perhaps be useful if we actually went around the table, for the new members as well as ourselves.
Okay, yeah, we could do that now if you like. I suppose I could introduce myself. I'm Ollie Vickers, newly elected councillor for Donington at their last election.
Yes, I'll be a new face as well. So I'm Sophie Foster, working for Shropshire Council as Overview and Scrutiny Officer, and I'll be supporting this committee.
I'm probably not a new face to many of you, but for some of you, so my name's Tom Dodds. I'm the Scrutiny Manager at the Council, and now Sophie's here. I'll be stepping back a bit and leaving you to attend administrations.
Rachel Robinson, so Executive Director for Health, Wellbeing and Prevention in Shropshire, DPH for Shropshire, Director of Public Health for Shropshire, and I'm the Executive from Shropshire Council perspective who sits on the our health overview and scrutiny, and then also on the joint task from a Shropshire Council perspective. I think I'm an observer. I'm not so I shouldn't really be at the table. So thank you for welcoming me today.
Simon Fogel, I'm from Healthwatch Telford and Wrekin. I'm the Chief Exec there.
I'm Hilary Knight. I think I'm a lay member for Telford and Wrekin. I don't know. I am still. Good. It would have been nice to have been told.
Hello, I'm Louise Price. I'm Patient Co-optee for Shropshire.
Hi, I'm Lynn Corley, Chief Officer of Healthwatch Shropshire as a co-optee, born and bred in Donington, so we can catch up about that later. But I live in Broseley at the moment.
Kate Halliday, I'm councillor for Bellevue Ward in Shrewsbury, Shropshire.
I'm Councillor Nigel Dugmore, Muxton Ward in Telford and Wrekin.
I'm Derek White and I chair the Telford and Wrekin Scrutiny for Health.
I'm Amanda Holyoak. I work at Shropshire Council as a committee officer and I send out papers and take minutes.
I'm Stacey Worthington. I'm the Senior Scrutiny Officer from Telford and Wrekin.
I'm Stanley Arnold, the Scrutiny Officer at Telford and Wrekin.
Okay, thanks everybody for that. Would any members like to make any comments about any of the items or, yeah, Kate?
I guess just a quick question following up on from Derek's suggestions about the ambulance service. Just the thought about whether we should be inviting them back at some point where it would fit in, whether it would be informal or not. But I think having heard that report, it would be nice to include them with some updates.
Yeah, Derek.
Can I suggest we end the recording now? Because normally we do an informal 10 minutes afterwards and discuss what we need to follow up from.
Yes, we can. I just want to reiterate what Sophie said. Members can add items to the work programme if required throughout the year. Thank you for attending. The next meeting will be on the 4th of July at 2 p.m. and that will be held in Telford. And I can now declare this meeting is closed. I'll let you know when the